Hi there, this is Dr. William M. Chansa, and in this video I'll continue with the laboratory values and investigations. Specifically in this video we'll discuss renal function tests and urine microscopy. So let's go. Okay, first things first, we'll discuss the renal function tests. Okay, so now what it means when they say the renal function tests, these are the tests that we do or that we order for the patient, see, where we assess for their renal function. Okay, we want to assess how their kidneys are working. Okay, how do we assess that? We assess how the kidneys are working by looking at certain parameters. Now, it's very difficult for you to know the functions of the kidneys if you don't know the tests that you have to order for. In other words, it's very difficult for you to know the tests if you don't know the functions of the kidneys. So you have to go back to the basics and learn the functions of what? Of the kidneys. So one of the most important functions of the kidney is what? Is excretion. Okay, so excretion is a very, very important function of the kidneys. And why is it important? Because most of the toxins, most of the metabolites that are produced in the body are actually excreted via the kidneys. Okay, and for that function, or for that being said, if the patient has got a problem with their kidneys, it means that they'll be unable to excrete such kind of toxins. Okay, so that's the most profound function that you need to know. Of course, there are multiple functions of the kidneys, but that is one of the most important one. The most pivotal one is excretion. That being said, we have to know whether the kidneys are excreting things or they're not excreting things. We have to know that, and how do we know that? Is to order for some tests which we call renal or kidney function tests, KFTs or RFTs. Okay, so now for these, usually we start with what is called the blood urea nitrogen. So this is just trying to help you to identify the urea levels in the blood. That's what you need to do. That's what you need to know. So you get the blood sample from the patient, and then you determine their blood urea, or the urea in their blood. Okay, that's what you need to know about this. The normal range is dependent on the units that you are using, and depending on the hospital setting that you are in, because these lab values actually get to differ depending on the hospital setting or the laboratory setting rather. So you need to remember that. But in milligrams per deciliter, it's 8 to 25. That's the normal BUN. So now BUN can be elevated. For now, I just want you guys to remember that if the kidney functions, okay, these parameters that I'm going to talk about, if they're elevated, it tells you to say the kidneys are not functioning properly. Okay, or there's something that is causing the elevation of such kind of parameters in the blood. So you need to remember that. That's what is important. I will not dwell so much in explaining what can cause elevation of the blood urea nitrogen, but you'd want to know anyways. You'd want to know what is causing that. One of the common causes of what elevated BUN is upper GI bleeding. Upper GI bleeding can cause that, so you need to remember that. But that's the most that's one of the significant ones, but there are a lot of, the list is endless, and I don't want to waste so much time on just one parameter. So that's BUN. The normal is 825 milligrams per deciliter. If you want to get memorize one for millimole per liter, okay, or just international units, that's you. And then serum creatinine. Now serum creatinine is very, very important. Serum creatinine is what? Is very, very important. Okay. So now, aside upper GI bleeding, dehydration can also cause elevation of the blood urea nitrogen. That's very important to remember. I just forgot to mention that. That's important. So that's about the blood urea. So you're just trying to determine the urea, which is a byproduct of what? Of protein metabolism. You know that. So especially the purines, after metabolism, you get to have urea, in high quantities. So that's the norm. Others will say 10 to 50 milligrams per deciliter, but that's the value that I got from my literature. Okay, so now from there we can move to serum creatinine. Now you need to know to say creatinine is just a chemical, it's a waste product of muscle functioning. In other words, if your muscle cells are being degraded, okay, or the breakdown of the muscle cells rather, will give you what is called creatinine. This same creatinine can be used as the energy by the body, okay, but it's a byproduct of protein metabolism, as well as what is called rhabdomyolysis. So rhabdomyolysis, there's production of what? Of creatinine. So now this serum creatinine has been used to identify, or rather to actually grade kidneys according to KDIGO, which is Kidney Disease Improving Global Outcomes. So that organization it's one that classifies acute kidney injuries in two different stages, and we use the serum creatinine as well as the urine output to identify what the kidney function. So it's very, very important to remember the serum creatinine level. The normal is 0.6 to 1.2. Others will say 0.6 to 1.3. That's okay. Milligrams per deciliter. If you want to normalize the one for micromole per liter, which is 70 to 118. Others will say 70 to 116. It's okay. Okay, that's fine. So that's for creatinine. So serum creatinine is just used to what? It signifies the protein metabolism and whether this chemical is being excreted by the kidneys or not. That's what you need to know. What are the differentials if it is elevated? So the differentials, the most important differential to remember is that the kidney is not working, it's not excreting things, it's not doing its excretory function. That's what you need to remember. So acute kidney injury, CKD, all these conditions can lead to elevation of what? The serum creatinine. And also rhabdomyolysis after exercising, and then you do the serum creatinine levels, they might be elevated. Okay, they might be elevated because of what? Rhabdomyolysis. Okay, that's for serum creatinine. Now, let's talk about the creatinine clearance. So creatinine clearance is just the same. It's just that function of the kidney to excrete or to eliminate what? To eliminate creatinine from our body. That is called creatinine clearance. And the normal is dependent on sex. So in the male it's higher than in the females. And I think it's about the muscle bulk that men have as compared to the females. I think that's the reason. And those are your normal ranges. Okay, that is for creatinine clearance, up to 140 in the male, up to 125 in the female. Okay, and then from there we can move to what is called estimated glomerular filtration rate. So glomerular filtration rate is the rate at which the kidneys are excreting things. Okay, the normal is above 90 milliliter per mil per 1.73 meter cubed of the body. Okay, that's for the area of the body. So the estimated glomerular filtration rate should always be above 90. If it's less than 90, then we are going to go into what is called AKI. Now, this is also used probably in CKD. If you are grading CKD, okay, you usually use the glomerular filtration rate. Very, very important to remember. It should be always above 90 milliliter per mil per 1.73 meter cubed. That's very, very important. That is what? That is for the estimated glomerular filtration. Okay, that's what you need to remember there. Now, we also add some electrolytes under the renal function test or kidney function test. It's very, very important because these are electrolytes that we have are very important, and most of the regulation of these electrolytes occur at the kidney level, okay, at the nephron level, meaning that we need to talk about them as well. So sodium, the normal is 135 to 145. You can have hyponatremia when the sodium is less than 135. You can have hyponatremia, and look at the details of this. So above 145, it's hyponatremia. Less than 135 is hyponatremia, millimole per liter. That's a milliequivalent per liter. It's the same thing. Okay, the units are the same. And then if we talk about potassium, remember sodium is outside, potassium is on the inside or inside the cells. Potassium is more of an intracellular electrolyte, while sodium is more of an extracellular electrolyte. Okay, so sodium is higher outside while potassium is higher inside. So you can have the normal levels of potassium is 3.5 to 5. Very important electrolyte, highly healed Okay, you'll be asked a lot of questions about with regards to hyperkalemia. You manage hyperkalemia. What are the ECG changes in hyperkalemia? What are the ECG changes in hypokalemia? You need to know that as a medical student or a medical doctor. So the normal level is 5 milliequivalent per liter or millimole per liter. That's the potassium. If it's higher than 5, we call it hyperkalemia. Usually when it's higher than 5.5 milliequivalent per liter, it's called hyperkalemia. If it's less than 3.5, hypokalemia. All right. So that's for your potassium. Let's talk about chloride. So chloride is also a very important electrolyte, right? And usually it's found in the extracellular component because of the sodium that is outside also. So it's no more easy. This one is straightforward to remember. It's 97 to 107. Okay, millimole per liter. Others say it's 96 to 106. So whichever one that you're comfortable with, you can go for it. Remember we talked about chloride with regards to metabolic acidosis. Okay, we talked about hyperchloremic metabolic acidosis and normochloremic metabolic acidosis. We talked about them and we know the differences between the two right now. So I will not talk about the issues that have to do with chloride levels, but you need to know that we have also chloride somewhere, and we have to understand its function. So that's for what? That's for chloride. Now, I think there's something that I didn't mention that is very important about what is called blood creatinine, okay, or creatinine clearance. It's something that I didn't emphasize. Okay, you need to know to say it's the most accurate measure of the kidney function. That is creatinine clearance. This is why if you've seen nicely, even the normal levels of creatinine clearance differ according to sex. So if you've seen in the male, it's very fast. Okay, 95 to 140 mLs of creatinine is cleared per minute. Okay, while it's in the females, it's 85 to 125 mLs per minute. So it's less in the female, and it's because of the muscle bulk. Okay, so you've gotten that. So it's most profound, it's more accurate measure of kidney function. Okay, is dependent on the age, sex, and poverty. We've just concluded the renal function test part. Now, let's talk about what is called urine microscopy. So, urine microscopy is where you get a urine sample. Of course, there's a way in which you have to get that urine, and that's a story for another day. So, you get that urine sample and take it to the lab for microscopy. Okay, they check it under a microscope. Okay, on a slide. So now, what you see in that urine is what we are interested in this discussion. And I've brought this topic in because I've been questioned. We've been asked a lot of questions on the wards. Okay, when I was a medical student, we were asked a lot of questions about urine microscopy, specifically what we call urinary casts. So I thought I should make a nice video about them so that everybody can have a view or can know something about what urinary casts. Very important topic, and I want you guys to pay attention to this part. Very, very important, because you're going to be asked a lot of questions in the exams, on the ward, and as a medical doctor, you just need to know the differentials for what you call urinary casts, because we have got different types of urinary casts that we have. So let's go. So urinary casts refers to a solid cylindrical structure that can be formed in microscopic examination of the urine sediment. These casts are formed within the kidney tubules, and may contain various materials, which can be proteins. You can have cells, you can have crystals. Okay, you can have other things, or you can have everything combined. So those are the crystals that you see, or the solid cylindrical structures that you see on the microscope. Okay, on the microscope of the urine that you've got. Okay, that's what you need to know. Now, these casts, which we are calling the solid cylindrical structure that are formed within the kidney tubules, they can help us identify the renal problems that the patient is encountering. So they can help us identify the urinary tract disorders. Urinary casts are formed when the proteins, cells, or other substances, they become trapped within the kidneys or the kidney tubules, and then they combine to create crystals or cylindrical structures. So they will just form structures which you will only see on a microscope. And if you know these, you know the differentials. It means that you know to say what the patient is actually suffering from is this condition. So that's why it's important to understand what is called urine microscopy or urinary casts. Okay, so there are different types of urinary casts that you are going to encounter or that you know. The first one being the hyaline casts. So the hyaline casts, they are primarily composed of what? They are primarily composed of proteins. Okay, they are also called hyaline cylinders. Others call them hyaline cylinders. Others call them simply hyaline casts. Okay, so you can have different names. And others say these hyaline casts, they are composed of proteins. They are made up of proteins. Okay, and the type of proteins that they are comprised of are called the term phosphoprotein. Okay, and this type of protein is just a glycoprotein that is produced by the cells within the renal tubules. Okay, so they may contain some proteins also that you might find in the urine. So now, in short, these iron casts, they can be normal. You get the point, because these are just like there's a protein that the cells in the kidney tubules produce, which is called the term phosphoprotein, right? Which is a glycoprotein. That protein is what you're going to see on a microscope. This is why we are saying urinary casts are just cylindrical structures that we see. And then the cellular casts, these ones, they contain what? Cells, which are cells, or it can be leukocytes, or you can have epithelial cells within the kidneys. So those are cellular casts. Then you have what you call the granular casts. So now, with regards to the granular casts, these usually others say they are a type of cellular casts. You get the point, or a proteinaceous casts, meaning that they can be made up of protein or cells. You get the point? Yeah. So now, they are sometimes referred to as what? Granular casts or coarse granular casts, meaning that you have got two types. You have got easy and coarse. Okay. Others will classify them as what? Hyaline granular casts. Those ones that are made up of what? More of the proteins. Okay, these ones are primarily composed of proteins. Like, for example, the same protein that we talked about, like the term was for protein, or the immunoglobulins. It can be immunoglobulins. These are also proteins, remember. So immunoglobulins, those are going to be called the hyaline granular casts. Okay, and then you can also have what you call the cellular granular casts. So now these cellular granular casts, they are made up of what? Cells. Okay, they are made up of cells in layman's terms. So they can have cells from the tubules, like the renal tubular cells. Okay, they can also have red blood cells or white blood cells or kidney cells or any type of cells. They can have them. So in short, when you're under granular cast, granular cast, you've got two types. You've got hyaline granular cast, which are made up of what? The different types of proteins. Okay, primarily made from proteins. Whilst the cellular granular casts, okay, the cellular granular casts, these are made up of cells, preferably cells. Then you also have what you call the wax casts. Okay, now, so for the wax casts, these ones, they are made up of the dense and homogeneous substances. These are called wax casts. Okay, others, they have also have what you call the fat casts. So the fat casts, they are made up of fats or lipids. So these are also called lipid casts. So the type of urinary cast that can be observed on a microscope, and these, they are characterized by presence of what? Fat droplets or lipid droplets within the same cylindrical structure that you see on a microscope. Okay, and usually these are usually seen in chronic kidney injury. Okay, chronic kidney injury. So now, just to emphasize a little bit about the wax cast, these wax casts are on microscopic examination, and they are called wax because of their how they appear, because they appear like a glass. It's like a glass. So those are called the wax casts. Okay, yeah. So the clinical relevance of the wax casts is that they are a sign of chronic kidney disease, okay, or just a sign of reduced kidney function. So these ones, they just appear like glass, like, yeah. That's what you need to understand about about the wax casts. Let's move. So now these are examples. So I've already explained, I've already alluded to each one of these components. So hyaline cast, we've said these are the most common type of casts that are found in the urine. They are transparent in nature and colorless, and they consist of mainly the protein which is called the term phosphoprotein, which is produced by the renal tubules. The presence of the hyaline cast can be normal or indicate mild dehydration, stress, or exercises, because remember, it's just the kidney cells that produce the hyaline cast, and these are the commonest. Then you've got what is called granular cast, which I said they are divided into two. You've got fine granular cast and the coarse. Others classify them as what? Cellular and hyaline granular casts. So we've talked about the granular cast already. We've said sometimes they can just be proteins, sometimes they can be what? Immunoglobulins are under the proteins. Remember, immunoglobulins are also proteins. Or you can have the same term also for protein that is produced by the renal tubular cells. Okay. And then you have got fine and coarse. So a fine one, they are fine granulated material and can be indicative of what? Kidney injury, such as acute tubular necrosis. Okay, so if they ask you ATN, acute tubular necrosis, is what? The differential for granular casts. And then the coarse ones, these can be a sign of more severe kidney damage. Then you have what is called the cellular cast, which we said we divide them according to the type of cells that are affected or that you see on a microscope. So you can have renal epithelial cells, you can have red blood cells, can have white blood cells, or both mixed together. Get the point? These ones also, they'll be indicative of what? Kidney injury or kidney damage or an inflammation that is ongoing, or indeed urinary tract infections or glomerulonephritis. So we'll talk about it. So for glomerulonephritis, you usually see red blood cells, because red blood cells are forced to pass, they are compelled to pass through the glomerulus and go in the renal tubules. So that you're going to see red blood cell casts in glomerulonephritis. Whilst in UTIs, you're going to see what is called white blood cell casts. So if they ask you this, you say white blood cell casts of what? UTIs. So if there's any infection in the genitourinary tract or urinary tract, you need to think of what? You need to think of the white blood cell casts. Because remember, whenever there's an inflammation, the cells will have to rush there. Or whenever there is an infection, the cells will have to rush to the area. Okay? And that is why you have got elevated what? White blood cell counting. You have got white blood cell casts on microscopy. And then you have what you call fatty casts. So fatty casts contain lipid. They are also called lipid casts. So these are droplets, and they are often seen in individuals with nephrotic syndrome. Remember, in nephrotic syndrome, they have got hyperlipidemia. Okay, we'll talk about the pathophysiology of nephrotic syndrome, but that's a story for another day. Okay, so when there's excessive loss of protein in the urine and lipids, you're going to have what is called fat casts. Then wax casts, I've talked about them. These are bloody, and they have got a glass-like appearance. They are typically indicative of chronic kidney disease or severe kidney damage. You also have what you call red blood cell cast. I already alluded to this. It tells you to say there is bleeding within the kidneys or somewhere. Now you have to be very careful, because red blood cell casts, you see blood, isn't it? You see red blood cells, but you have to identify the type of red blood cell you're dealing with. Are they dysmorphic, meaning that the cells shape are distorted? Okay, the shape of the cells are distorted, then it means, or the shape of the cell that you're talking about, that you've seen on the microscope, is distorted or damaged. It's called dysmorphic red blood cells. If it is like that, then it is indeed glomerulonephritis. Okay, it's indeed glomerulonephritis. Okay, but if red blood cells are okay, it means that the patient is bleeding maybe along the urinary tract. Okay, it could be in the ureters, it could be in the bladder. Okay, that is why you are getting such kind of a picture. That is if the red blood cells are normal in the morphology. But if the morphology is distorted, then you think of nephritic syndrome as your differential, also called glomerulonephritis or kidney inflammation. If you see white blood cells, these are casts made up of clumps of white blood cells together, and they are typical signs of what? Inflammation or infection within the kidney or the urinary tract. Then if you see the crystals, so these crystals, they are more like stones, in other words. So crystals are a collection of things. Okay, so these are composed of crystals, and usually these are just stones, like the calcium stones, calcium oxalate, okay, uric acid stones, struvite stones. Okay, you can have what is called cystine stones. You get the point. So different types of stones, they find what you call crystals, because they are a collection, they are a constellation of crystals, like electrolyte, for lack of better term. So they collect together and then they form a solid thing which you call a stone. So usually those are called nephrolithiasis, or a stone in the urinary tract is called nephrolithiasis. So you need to remember that. That's for crystals. And then mucus casts, this is because of mucus is collecting in that area, in the kidneys, and it's because of chronic kidney disease. Yeah. So now this is just a clinical picture or a microscopic picture of what we've talked about. So hyaline cast, which is said are normal proteins that you see. Hyaline with fat. Sometimes you can have hyaline with fine granular. You can have also cellular to coarse granular. We talked about granular. We said we divide them into two: cellular and what? and hyaline. We've talked about that. Remember, we also said the granular can be fine or coarse. These are the things that you are seeing on the screen right here. Now, it's very difficult for you guys to appreciate what I'm showing you on the screen. So it's recommended that you just go on Google, you search for each and every urinary cast and check how they appear on microscopy. So for the purpose of this video, I'll only show you one, which I know is very highly healed. Okay, it's very, very important to know these casts that you are seeing on the screen. Sometimes they can just eventually come in the exam and you find them like that. They just ask you to identify and tell them the differentials that could have led to that kind of cast to be present in the urine. So you need to know that. Again, this is just also a summary of everything that we've talked about, but I'm interested in red blood cell casts. You've seen these are red blood cell casts, and this is just a diagnostic of what glomerular disease, especially glomerulitis. If you're asked about the differentials, any inflammation of the kidneys, nephritis, glomerulitis, IgA, whatever, as long as there's damage to the glomerulus, then you have to think of what red blood cell cast as the most important thing that you can see under urine microscopy. And then if you see dysmorphic red blood cells, meaning that the red blood cells shapes have been distorted, then that is also something that you need to think of. So glomerular disease, but it can also be seen if urine sample is not fresh at the time of microscopy. Okay, now you have got these are the epithelial cells. Okay, epithelial cells, and that's your normal thing, because you have got these cells that are shedding from the urinary tract. Then in renal tubular, you can also have what you call renal tubular cells. Remember, we said under the cells you can have epithelial cells. Okay, these are the renal tubular cells. You can have non-dysmorphic red blood cells, which tells you to say the bleeding is not glomerular in origin. It's from anywhere else in the urinary tract. I've already alluded to that. But if the cells are dysmorphic, the red blood cells are dysmorphic, meaning that the cell's shape have been distorted because as the red blood cells were compelled to pass through the glomerulus. So that's diagnostic of what? Of glomerular disease. Okay, red blood cell casts, we've talked about them. Leukocytes, we've talked about them. Therefore, urinary tract inflammation or an infection. And then you have the white cell casts, renal infection, hyaline cells, any type of renal disease and normal. You can find them, the hyaline casts. Then the granular casts, we've talked about them, and they are more specific for renal disease, because remember, you see a lot of proteins in there, which can be immunoglobulins like IgG, IgA, whatever. You can find them in there. And then also you have what you call the Benz-Jones if you are suspecting what is called multiple myeloma. Okay, so you can have different types of proteins in the urine, and they can give you different types of what? Different differentials, in other words, or different conditions. Okay, that's for glandular casts. Very, very important. You can have what you call muddy brown casts. So muddy brown cast is specifically for what is called acute tubular necrosis, ATN. So acute tubular necrosis, you see muddy brown casts. Okay, then clystors, I've talked about them. These are just clystors, and they can be found in healthy individuals, and they may be indicative of what? Metabolic problem, like for example uric acid stones. You can have struvite stones. You can have different types of stones. Okay, that's for clystors. Then bacteria, you can see bacteria also under the microscopy. Okay, and it can be indicative of urinary tract infection or just contamination of the urine that you collected from the patient. And then this is just like a summary of what we've talked about. But remember, mud brown cast is for what? It's for acute tubular necrosis here. So in short, you can classify the urinary problems or kidney problems into three. You have got before the kidneys which we call pre-renal, or into the kidneys, within the kidneys which we call intrinsic, and then after the kidneys which is called post-renal. Yeah. So if a patient has got chronic renal failure, you're going to see wax or broadcasts. Okay. Then if it's pre-renal, usually it's hyaline cast, which we said they are just produced. They are normal, usually normal, but they are commonly seen in different conditions. They can also be found in normal individuals. And then you have got under intrinsic, if there is acute tubular necrosis, muddy brown casts. Okay. And then if the patient has got an allergic interstitial nephritis, they have got an inflammation of their nephrons. Okay. Within the interstitium of the nephrons, then you have to think of what is called you'll see what is called urine eosinophils. So you're going to have eosinophils a lot on a microscope or under a microscope. And then glomerulitis, we have got nephritic syndrome. So nephritic syndrome, you'll see red blood cell casts. I've already talked about that. And then fatty over bodies or fat casts or lipid casts are usually seen in nephrotic syndrome. Okay, that's the summary of everything that we've talked about under urinary casts. Thank you very much. I hope this video is going to be helpful to you. Okay, that was Dr. William M. Chansa, SMTCO 2026, signing off. Goodbye and good luck in your medical school.